All right, kids, let's begin with patient assessment PowerPoint. Everybody ready to go? You have your National Registry assessment sheet pulled up. Need to duplicate on here. You want to pull up medical. Duplicate. Alright, so as we talk, you'll be referencing your National Registry Medical Assessment Sheet. Just make sure you have that out so that you can take notes on it. I gave you the link to the assessment sheets and all the National Registry sheets so that you can have multiple copies. I would probably imagine that you're PT out for the skills manual book where you make the notes versus you could take copies of the other ones in class. Some of my students laminate them, so dry erase on it. Whatever your method is, you'll need more than one copy. I would argue the one in your book should be your note-taking copy.
That's not your signature, so I know. I said it through that.
They're on JBL underneath Teacher Helpers, National Registry of Skills.
Yeah, cool. Thank you.
Very good question. Where is the sheet? Where are the sheets? They're on JBL under Teacher Helper, or Justin, whatever I call it. All right, everybody good? I am recording this lecture. It is already recorded on other YouTube versions on my channel, but those versions probably have bad words. So I'm going to try to do better and not cuss at all, or hear my dog barking. All right, so this module is composed of Chapter 10 and the Airway chapter. So the next module exam you do is on August the 7th or the 8th, is that right? Am I talking about it right? Is that Monday or Tuesday, August the 7th or the 8th? Yes, it is. August 7th or 8th, you will take Module 2 exam, which is composed of assessment and airway. So in the next couple of weeks, we're doing assessment and airway. One of the big things you've got to get down about assessment is what is composed of each part. So we have to do two things. Teach you what composes the section and then teach you some memory techniques to memorize how the sheet works. And so as you look at the sheet, the first thing you're going to come to is the block of scene size up. I need you to see the sheets as blocks. You cannot probably, some of you probably can, but I don't think most people can absorb all of that by just looking at it below them. It's intimidating and it would bore you, and so you would just check out. Versus if you broke the box up and you learned them by the boxes, I think you're more successful. You're more probable to be successful with that. Okay? Let me turn this way so the microphone is pointed towards me. I'm trying to do as much as I can with technologies, because get as much as you can get out of the lectures. You can go back and watch them. Okay? So we look at the first block. I've told you what this is about. We're looking at the first block, and it is the scene safety, scene size up block. This is conducted on the way to the call, and it's conducted as we arrive to the call. This is something we call the windshield view. You're getting those things, and we're going to give it an acronym, and the acronym is SNACM. Okay? S-C-N. Did I do that right? Let me just write it, because there ain't no way I'm going to do that right. Let's just write that down. Okay? SNACM is S-N-A-C-M. All right? Maybe I won't pull up something bad in Word, like someone's disciplinary action or something. That would be normal of me. All right, so you have SNACM. And SNACM stands for Scene Safe BSI. That's the S, Scene Safe BSI. Number of patients, ALS backup or additional resources. Do we need C-spine? Mechanism of injury and nature of illness. Now, the slides are going to go through each one of these, piece by piece. So don't break your neck, just write down the acronym. SNACM is the entire scene assessment block. It is the same across all assessments. And so this acronym can be used across all of your assessments. Scene safe, do I have on BSI? Number of patients, how many people are here that need help? ALS backup at a minimum, but the A also stands for additional resources. Do I need a high-angle rescue team? Do I need extrication? Do I need confined space? Do I need trench rescue? Do I need a bike team because there's so much saturation of people and vehicles that I can't get people to the patient? Additional resources. Do I need a helicopter? But ALS backup is the minimum of this class. Every time we do an assessment, when you get to A, at a minimum, you will call for ALS backup. That ensures to me that you will be successful on the exam because the National Registry's perspective is that anytime an EMT deems a patient an emergency, you look upon the patient and you say, whoop, yep, this is bad. This is an emergency. That you would, at a minimum, try to get ALS backup. You might work somewhere where it's not coming. It might be delayed. It might have started but now can't get to you. All kinds of variables. But at a minimum, you would request ALS backup. Okay? The C is do I or don't I need to take manual stabilization of the C-spine, which is merely having your partner hold the patient's head still. This is not a C-collar. This is not devices. This isn't immobilization. This is simply you've heard enough information to say, ooh, I'm really worried about Joe's C-spine. Malachi, take C-spine until I find out more information. That's why it occurs so high on the sheet. Because if you forewent it, you can't get it back. The time you weren't holding that C-spine, you cannot get that time back. Agreed? So say you go to an 80-year-old female who has fallen, but she's now up in her recliner. You might say, partner, hold C-spine until we get more information. It looks like she probably won't be immobilized. But we'll hold it for now till we interview her, get our assessment down enough to say, okay, we're foregoing C-spine. So it's always good to hold it in the beginning and let it go if you don't need it. Okay? Is it common for you guys to use C-spine on a medical patient? No. So if in a medical patient you encounter, you said, hey, sir, any slips, trips, or falls today? And Joe says no. You would say to the examiner, I'll forego C-spine at this time. So don't let the acronym make you think that it is necessary. It's a judgment call. All of these things are a judgment call. That's what assessment means. You receive information and you make choices about it. Does that make sense? That's SNACM. So MOI is what? Mechanism of injury, while NOI is nature of illness. We're covering a lot of acronyms really quickly, and so you better be writing them down. You better be making flashcards. You can't get through this class without these acronyms and these flashcards. Okay? Mechanism of injury is used if there is a mechanism of injury. Fall, blunt trauma, penetrating trauma, high fall, submersion, atmosphere problems. That would be a mechanism of the patient's problem. While nature of illness tends to follow medical patients, right? So mechanism of injury tends to be trauma, and nature of illness tends to be medical patients. Can anybody give me a broad, non-specific, big umbrella version of nature of illness? The patient complains of what? Chest pain, shortness of breath, back pain, abdominal pain, my leg hurts, my right toe won't bend. All of those are natures of illness. Whatever crap globally was the reason you got sent there. If you're looking at the EMD cards, EMD 26 is sick person. So then the nature of illness would be sick person. And then we go there and we interview and we get information. We find out the details of what sick person means today. This is a cardiac arrest. They weren't sick. Right? So, mechanism of injury, nature of illness. If you remember SNACM, you have completed the entire first block of the patient assessment. Let me show you how fast this goes. Justin, you were responding. It is the same time and temperature and day as it is right now. You're a BLS ambulance. You have yourself as an EMT and 2 crew member EMTs, and you're responding to the private residence of a man complaining of chest pain. All right, I arrive on scene. I'm scene safe. Yeah. Is my BSI on? Yeah. Okay, how many patients do I have? Just this one? Yes. I'll go ahead and call for ALS backup. You said it was chest pain. That's an ALS complaint, and I'm going to move forward. So now I've done A. I'm going to go to C. Sir, any slips, trips, or falls today? My name is Justin. I'm going to take care of you. C-spine is foregone. Nature of illness is chest pain. Done. Block is done. All you got to do is commit it to memory and then go, 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 go. You're checking boxes. When you see us on scene of a bad call and we're just flowing, we're not magic. We're not amazing. We are checking boxes. When you see a trauma surgeon at the head of the table and they're just calling for thing after thing, it's not magic. We're following a sheet. We're following an algorithm, and nobody knows that. Everyone thinks that we're just holding on to all this information. Nope. We've made it muscle memory. You give me a complaint, and I can flow that entire algorithm because we've memorized them. And so will you. It doesn't matter how nasty I make this call. Hey, you respond to 72 babies washed up in the surf. You're still receiving gunfire from the south, and there's a fire in a nursing home just adjacent to your Bravo side. Jesus. You'd still get there and be like, all right, scene set, BSI. How many patients? So if you follow the algorithm, it works for the little man in his house with chest pain, and it works for 72 babies burning in the surf. No matter what call you apply it to. Does that make sense? All right. Snack them. Anna, what is snack them? Give me the pieces. Quickly. She's like, why me? What's snack them? CSA PSI. Everybody? Number of patients. ALS backup. C-spine yes or no. MOI and OIs. Okay? Now, when we learn these acronyms, you're going to know that they're more complex than they are on the surface, but you know that. You know that in your head. Additional resources, technically, is all the things, whatever. We're going to call it for ALS backup. So, I'm going to go over that again. C-spine number of patients, ALS backup, C-spine yes or no, MOI and OI. That's it. And that is the first block of the sheet. If you break these blocks up like we just did, it is doable. Easily doable. And you will have this assessment committed to memory. By the time we leave this class, you will not be able to proceed if you don't have this committed to memory. The sheet from the top to the very bottom. You cannot complete this class without it. Everybody look at the sheet. How many points did you ask for? 42. I don't know how many points you need. They won't let me know. They only tell me the critical phase. Instructors aren't allowed to know how many chronological pieces and parts you can miss and be okay. I'm not allowed to know. So then you must commit it to memory. That was by design. Everybody go with that? I told you the Mark Coates story. He's on the side of the interstate fighting for his life, and he polices his .357 caliber brass because they taught it that way. Every day at the academy, he was firing those rounds and then picking them up. Firing those rounds, picking them up. And in the heat of battle, with .22 caliber rounds coming from a little stupid Derringer pistol, he's at the front bumper picking up brass. Muscle memory. As much as that was for the bad, we can build that same amount of muscle memory, that immediate response from you that you don't have to consciously do. We can build that muscle memory, and that's what the sheets are designed to do. Everybody understand SNAP? All right, let's go through the slide version of that and make sure that we addressed all that it encompasses. Okay? Obviously, you know why we're assessing teams. What is it we're looking for? Well, if this is a traffic accident, don't open the side of the ambulance and just step out. Don't get out of the Bravo seat on your radio doing your seat size up and just step out in the road. How many times do we see that? We're so in tune to getting it right, not sounding stupid. I know XYZ person's listening to me. I don't want to sound like an idiot. And so you are in tune, given that rehearsed scene size up, and then wham! You're dead on the side of Ashley Phosphate. That happened. That occurred. That person has no legs. They had legs that morning, and they went home with their legs. Not okay. All right? So scene safety, what does that mean to you? The obvious stuff, and then there's the subtle stuff that we've got to practice, like not stepping out into open traffic. Wearing your safety vest. If there's an electrical line between you and them, don't go between you and them. Does that make sense? All right, so each individual components have material to be read about in the book that I'm not going to cover here. It has examples, versions, points it thinks are important, how to shuffle with electricity problems. Scott loves that stupid question. You'll see a stupid question that says, it's already touching the ground. There's a line on it, and it's electrified. How do you get them to you without killing them? Well, they got to shuffle some stupid crap, and so read that in the book. Okay? They can't hit their feet and get off the ground and make that connection, can they? They've got to shuffle. So read about the individual pieces and parts of that. Obviously, that is your SNACM. Okay? Then we'll move into your primary assessment. Okay? Your primary assessment's job is only to decide if the patient is really bad off, then treat them for shock if they are, and leave. Or, they're not really bad off, this isn't really a huge emergency, we can stay and play. Okay? The first patient I gave you was a load and go, and the second patient I gave you was a stay and play. You remember that verbiage? We discussed this in the last eval assignment. So the primary doesn't require cardiac monitors. Typically, it doesn't require a stethoscope. Typically, it doesn't require SpO2 or BGLs. It is a manual assessment done from your interview with the patient using your senses, your sight, your mouth, your ability to feel, touch, and discuss with the patient. Does that make sense? So when you look at the primary, you'll see that the very first thing we do is walk up to the patient. We've already got some rapport, right? Because you saw me interact with Joe. No C-spines needed. His nature of illness is chest pain. My next thing is general impression. Test question. How does general impression differ from the rest of your exam? You didn't have to touch on it. General impression is as I walk into the room where the patient inhabits, I look upon them and say, whoop, he's in trouble. General impression is walking into that space and looking at the patient and saying, sit or not sit. That is a general impression. It does not require any touching of the patient, verbalization from the patient, interview of the patient. It's merely looking and saying, well, he don't look like he's breathing. Well, he doesn't look conscious. Well, he's very, very pale. That's a general assessment, all of which that would say, this ain't good. Central, this is not good. Start me some additional resources. Get me another engine. Give me another ambulance. Just that simple. That's what general impression does. Okay? So you'll see us walk in the room, and sometimes you'll hear medics say old school stuff like, sick. And everybody's like, what the hell are we randomly saying sick for? That is to inform everybody else that's in my caliber that this is going to be a Cat 2. This is going to be emergent. We're going to get ourselves together. Start moving. Get equipment. Let's go. Okay? That is your general assessment. After general assessment, you find what? AVPU, GCS, Glasgow Coma Scale, which will reserve for trauma. This book does, not my opinion, but the book does. So AVPU, consciousness and orientation, correct? That is where we say, is a person responsive? How much are they? Is a person conscious? Yes or no? Is a person oriented? Yes or no? Is that correct? And so I would simply say, Joe looked at me when I walked up to him, so he is alert, he is conscious because he's holding his own body posture up. Joe, what's your name, man? Where are you at right now? Is it morning, noon, night? Okay, what's going on right now? Why are we called here? You've got what? Some chest pain? Okay. He's A&O to person, place, time, and event. Alert and oriented to person, place, time, and event. You agree? Box checked. Moving forward. The next box is chief complaint and life threats. I look Joe over and I say to the examiner, anything crazy? Is he going to die right now? Is he bleeding? Is he choking? They say, no, there's no life threats. Okay? Joe, what's your chief complaint? What's going on today? Chest pain. Any other complaints? Okay, he's got some chest pain. I've now completed general impression, AVPU and orientation, and I've completed my chief complaints and life threats. So we do that. In the medical patient, there are no large life threats like you would see in the trauma patient in high numbers. The only thing I can think of is that the patient would be choking. That would be an emergent life threat. The patient would have an extreme stridor. That would be an emergent life threat. Does anybody remember what stridor is? We talked a little bit about it in the anatomy of the physiology chapter. It's that high-pitched squealing noise of the upper airway closing. That would be a life threat that I might need to pay attention to right now. Maybe there's something in the airway. Maybe the tissue is swelling. If that was a burn patient, I'd start getting on the radio. This is Cat 2. This is bad. I need a medic. Right? Are you going to be able to crank them? Are you going to be able to cut a hole in the road? Are you going to be able to intubate them if you can't get on the team too? No. So you better get the next thing coming to you. Right? So we've done now our life threats of medical. There aren't many. It will probably be no. There are no life threats in the medical world. So then we move on to chief complaints. Does that make sense? Be able to know some life threats. The book is going to give you some of the medical patient, and they're going to give you some of the trauma patient. So be able to know life threats. In the medical world, bigger one I can think about is choking right now. Foreign body airway obstruction. Okay? And FBAO, foreign body airway obstruction. That would be a medical life threat. But then you ask them the chief complaint. Why are we asking the chief complaint? Because some people say, well, we not already know. What dispatch told you is the best they were able to do with whoever was talking to them. And lots of people choose to talk to them. And almost all those people are useless. They give all kinds of wrong information. They can't be coached. They're out of their minds. They either won't help or they're dramatic people in general. If you don't know this, most human beings have emotional maturity of a toddler. They are not capable of calming down enough to say, someone's going to die if I don't calm down, think, and breathe. Someone's going to die. Most humans are not capable of that. In fact, the United States military and emergency services of this country spend a lot of time teaching people how to do just that. Calm down. Calm down. You can't save people. So you're not getting correct information from dispatch. And you're going to have to be that common force when you get there. So we're asking chief complaint again because it might be different. Maybe you find out that the wife thought they were having a problem, but the patient says they're not. So you got to ask that chief complaint again. Then we get to A, B, C. Those are kind of easy, right? They were before this class. Probably not too hot and easy right now. ABCs, airway. Is it open? Is it clear? Write that down on the paper. Is it open? Is it clear? That is the question we are addressing in airway. Is it open? Is it clear? We're going to address how to do things. We're going to dig into each piece and compartment, but right now you're learning the overriding foundation. Is it open? Is it clear? And if it weren't, I'd open it and I'd clear it. It's just that easy. And so when we get to airway, we're going to talk about what that looks like, what that means, what are your tools, what are the ideas that we do that with. Okay? Is it open? Is it clear? We get to B. You guys already know the question we're asking in B. What algorithm do we deploy in B? What acronym do we deploy in B? What is the patient's blank, blank, and blank? RRQ, which means what? Rate, rhythm, and quality. If you didn't know that, you better start knowing it. What is the patient's rate, rhythm, and quality of breathing? You already know what it should be from the chapters we've covered thus far. And you know what bad looks like from the chapters we've covered thus far that we will continue to build on. Then we get to C. What is the acronym we're deploying in C? What does C stand for? Circulation. And we're deploying RRQ again, Joe. Very good. And it is rate, rhythm, and quality of a what? Radial pulse or a carotid pulse. In conscious people, we tend to check radial pulses, and in unconscious people, we go straight for the carotid, except in what population? Babies, in which we would check a brachial. People are listening, I like it. Okay, that's ABCs. Addition to the pulse check is skin. What do we check in skin? What's the acronym there? CTC, color, temperature, and condition. What does condition mean again? How wet are they? Are they sticky? Are they dry? Are they diaphoretic? What's diaphoretic mean? It doesn't just mean sweating, it means excessively sweating. The book will say profusely sweating. You agree? Okay, that's what it means. So that's C. We're going to do a rate, rhythm, and quality of a radial or a carotid, and then we're going to do a color, temperature, and condition of the skin. And after we've done general impression, AVPU, life threats and chief complaint, A, B, C, we say to ourselves, is this patient showing signs of shock or not? And if they aren't, do whatever. I don't care about those patients. They're not the patients I'm teaching you about. If they are showing signs of shock, we'd simply treat them for shock. This moment forward, the treatment of shock is high flow oxygen, blankets, and appropriate positioning of the patient. Do I want them supine? Do I want them in Fowlers? Do I want them in semi-Fowlers? Want to go to jail? Would you like to? That's the treatment of shock. High flow oxygen. Blankets to protect the patient's warmth. We know that cold people in shock die faster and more often than anybody else in shock. And what position should they be in? If I'm having trouble breathing, please put me in Fowler's position. If I'm not having trouble breathing and my blood pressure is really low, please put me supine. Those are the appropriate positions. You must choose one. You cannot adopt one as the dominant adoption. There must be a decision made based on that patient's condition. Does that make sense? Yep. So everyone says the treatment of shock is high flow oxygen blankets in supine position. Well, that isn't true. You put a person having an airway problem in supine position, that would be a critical fail. You just lay the person back, you can't get their air. Can they get air better now? No, much worse. Agreed? So it isn't simply a position, it's a choice of position. Everybody understand? Let's go back to the top. I did general impression. I did AFPU in orientation. I did live threats and chief complaint. I did ABCs, and then I treated the patient for shock. Now we should get the hell out of here. Look on the sheet. It says, makes transport decision. The start of the primary is general impression, and the end of primary is that you said, we're going to package the patient emergently, and we're going to emergently transport the patient. And the verbiage I just used is the only verbiage allowed. This is a load and go. This is an emergent patient. We're going to package emergently. We're going to load in the ambulance emergently, and we're going to transport lights and sirens. You must make that clear to the examiner, and more important, you must make it clear to yourself that you identify the patient as a time-sensitive emergency. Everybody agree with that? That would be the verbiage you should use. It says on there, identifies priority. You might go to a county that uses priority 1, 2, and 3, and 4. You might go somewhere and use category 1, 2, 3, and 4. All that stuff's all over the place. But the word emergent means emergent no matter where you are. So that's what we're going to go with. Emergent, load and go. I'm going to emergent and transport the patient. Lights and sirens. You must make that clear to the examiner. What is the first step of the primary? What I just said to you is a test question. Black and white. That's what this test will look like. The assessment module will look like. Where do you take a blood pressure? In the secondary. Where did you get number of patients? In the scene size up. Did you whip out your blood pressure cuff in the primary? No, I did not. That's how you take the module exam. It's just that cut and dry. Where did this piece of the puzzle come from on the sheet? You cannot pass the module assessment if you don't know the sheet, because that's the exam right there. You just got the patient test to what portion of the secondary. That's the module exam assessment right there. Okay? Here's the other beautiful thing. From this moment forward, after assessment forward, the test questions that come in scenario form will be based on the chronological order of the sheet. It will say you have done such and such and such. What would you do next? And the answer is whatever comes next on the sheet. You're not actually being asked, and this is important for some of you overthinkers, Maddie. You're not actually being asked, and I'm not calling you out, I'm just helping. You're not actually being asked to think about the treatment. You're simply being asked what comes next. If I just gave them oxygen, I'm in the primary, I just gave them oxygen, prescribed transport, what's next? Blankets and positioning. It's what comes next on the sheet. It required no thought. Some of you get deep into all the knowledge we've taught you. So then you'll miss that question simply because you weren't keeping it simple. You weren't staying in the lane. What is simply next on the sheet is all that's being asked of you. The questions for the National Registry exam come in chronological of the assessment sheet. If you don't remember that, you're going to miss questions that are very objective, very black and white, but they dilute them down with such a big scenario that give you all this fluff and meat and potatoes, you miss the simple point of the question. Does everybody understand that? Okay, so if I told you that you have completed a primary, you treated the patient for shock, what's the next thing to do? Transport decision. And what are we going to do with the patient exhibiting signs of shock? Emergent. You guys are doing awesome. Does everybody understand the point of a primary? Okay, we don't whip out the big cardiac monitor on the primary. Look at all the things they talk about with the primary. Okay? Now we're going into the secondary. I told you the scene size up block starts with the S in sample, and it ends with the MOI and OI. The primary started with the forming of a what? General impression. You'll get good at that verbiage, and you must learn this verbiage. General impression is formed. Did you have to touch them? No. And then you ended the primary by doing what? You emergently transported the patient. Change your verbiage right now. You ended the primary by doing what? Emergently transporting the patient. So after that has been said, it leaves your mouth. It is assumed to have been done, and we are now beginning the what? Secondary. Look on the sheet, because this is a little confusing. The sheet says history. Everything after getting in that ambulance and going to the hospital emergent is the secondary. There's different verbiage that is the exact same words. We're saying secondary exam, meaning a head-to-toe assessment of the organs. And then there's the secondary exam, which means everything that comes after emergent transport. See how that could be a little confusing? Don't be confused by it. The moment the patient's in the truck and you're bouncing down the road emergent to the hospital, you are in the what? The secondary. Which begins, Joe, with what? History taking. Which brings us to our next acronyms. Sample. Sample. Sample is our history-taking acronym. We did all of this, everything that I just said to you. Okay? Sample is our history-taking acronym. And the S in sample stands for what? Do I know? Signs and symptoms. What is the difference between a sign and a symptom? A sign is something objective that they cannot change. If you were going to say the signs and symptoms of nausea and vomiting, which one of those things is a symptom? The nausea. I can't prove they have nausea. They say they do, and I just have to believe them. I can kind of look and see if a person's nauseous. But a person could be nauseous and not exhibiting any gross signs. But the vomiting, the moment they vomit, that's a sign that the nausea was true. Everybody agree? Patients tell us things all the time that the signs don't seem to say are true. You come into the room to a 17-year-old girl that just got done having a big talking to the principal's office, and they call 911 because she has a sudden onset of trouble. She's looking like she's going to die. But she's lying flat on the ground supine, having trouble breathing. Does that line up? No, because if I was having trouble breathing, I wouldn't pass flat on the ground. Would I? I'd sit up. She is breathing 12 times a minute. Does that line up? No. She's talking to me in full sentences, answering my questions in full. Yeah, I'm having trouble breathing. I just can't catch my breath, and I have a history of asthma, and I take multiple medications for that. And I'm just stressed about my mama and my daddy. I need them to come here and help me out. Do people struggling to get air have that much air to talk? No. We call struggling to breathe people 2 to 3 word dyspnea. They can only get out 2 to 3 words before they must take another breath. That's not lining up. You throw the SpO2 on her, it's 100%. That line up. So she can symptom all she wants. But the signs don't suggest her symptoms are true. Do we tell her that she's a lying to crack that class? Hell no. We want to. You load her up, you take her lying butt to the ER. That's what you do. That's how we do our job. That's what we do. But we know I'm not putting her on breathing. I'm not giving her a breathing treatment. I'm not giving her epinephrine for subcutaneous or IM rescue drugs for breathing trouble because she's none of those things. So she might think she's having trouble breathing. It might be all her thing, but it ain't hers. She doesn't have those signs. Know the difference between a symptom and a sign. Okay? That's the S in sample. What's the next thing in sample?
Allergies.
Allergies. Do you have any allergies? Medication allergies? Do you have any environmental allergies like nuts, bee stings, whatever you might be able to come up with? Lots of people have allergies. I swear we're getting more and more every day. And then we say M. M is what?
Medication.
Medications. Are you taking any medication? People who take medications are likely to experience disease for which they take those medications. Maybe our diagnosis that we're trying to form here is simply something they already have. Okay? What medications you take? Medications also cause things to happen. You can take St. John's wort and your whole muscles will fold up on you and squeeze you into a ball. It's called dystonic reaction. So maybe if you told me that, one piece of the puzzle, I would now know what's wrong with you. The history taking is how we start diagnosing the patient. The M stands for medications. What's P?
Past pertinent history.
Can you have past pertinent history that you don't take medication for? And that's why we separate. Remember with it? You can certainly have medical history that is super important today, for which you have no other indicator. Okay? What if you had 2 ectopic pregnancies and today you're a childbearing age female doubled over with lower quadrant abdominal pain, you look diaphoretic as hell, you're tachycardia, you're tachypnea? I'd beg to say that what has happened before might very well be happening again today. Let's get the hell out of here. Does everybody understand how sample works? What its purpose is? Pertinent medical history. What's the word pertinent mean? Important. Okay? You're going to find that to be a really good word because people like to be like, when I was 6, so you're 72. But when I was 6, I had a brake pedal stuck in my thigh. That don't have shit to do with your chest pain today. All right? It doesn't. So you're going to find that pertinent part will be really good for you. What's L?
Last oral intake.
Why is that, Max?
It could be what's wrong with them now.
It could be what's wrong with them now. If your last oral intake was a brownie, you're allergic to nuts, but you swear there was no nuts in that brownie. Bull crap, there were nuts in the brownie. Your whole tongue was swollen, you can't breathe, you're wheezing, sneezing, coughing, pooping. You were having an anaphylactic reaction. There were nuts in that brownie. See how that works? What about this? We want to put a tube in their throat. What happens if I put a tube in your throat? If I was to try to put my finger down most of your throats right now that's most, because some of you are extra talented. But there are some of you would gag, would you not? And what comes after the gag? All that stuff you ate. Anybody ever had surgery? Raise your hand. What did they tell you to do before the night of surgery? Do not eat anything. Because if you do, when I put this tube down your throat, you're going to aspirate all that stuff, and this is going to be ugly. Everybody good with that? Let it go, people. We're being recorded. So last oral intake has a lot of purpose. Are we going to encounter aspiration because they're currently a full stomach? Did they eat something that causes what's happened today? That's very important. Maybe you got a 17-year-old on a football field who's been practicing for 5 hours in South Carolina Heath, and he tells you his last oral intake was breakfast, and it's 6 p.m. That okay? And yeah, he's hypovolemic. That's what's wrong with him. He doesn't have the fluid to support his activity. That make sense? Last oral intake. E, events leading up to. That one's pretty obvious. Whatever it was that you were doing and whatever's happening right now are probably connected somehow. Okay? What's the last event you had? I was saying, I was at. And what did you do? I jumped. All right, this is obvious. All right, events leading up to. Or you say, I was having chest pain mowing the lawn. I stopped mowing the lawn. I came inside, and now my chest pain's gone. Is that events leading up to pretty good? Yeah, you've got a blockage in your heart. And you might be okay now. You might not be having a heart attack now, but if I exert you and you suddenly have that crushing, horrible chest pain, you become diaphoretic and it runs up your left arm and jaw, you're not okay. It's not over. The emergency is not gone. It's waiting. Get in the truck. You see how important this is? Events leading up to. Let's go back to the next acronym that we use. This one's more associated with medical patients, and it is diagnostic. I told you that we get a sample for safety, so that we don't do anything stupid to the patient. If they're allergic to aspirin, I'm not going to give them aspirin now. We get a sample to help us understand more about the patient. We get a sample to help us diagnose. But in a trauma patient, you don't really need a diagnosis. You can look at the chest and be like, oh, there's a hole there. That's what's wrong with them. You don't really need an OPQRST. So if you looked at the trauma sheet, you'd see that OPQRST is not on it. It's not on there. Because OPQRST's job is to diagnose a patient with a field impression. Everybody find field impression on your sheet. Everybody see field impression? Do you see field impression on your sheet? Circle it. It says forms field impression. States field impression. Circle it. And out beside it, put diagnosis, because that's what a field impression is. But we're going to call it a field impression because doctors get to bill for diagnoses. Don't. Silly, silly, silly. A field impression is your diagnosis. Your sample and your OPQRST's job is to reach your field impression. Is everybody with me? You're going to get a test question. Why do we do this? Is it just an acronym? It's just stuff we memorize. It's how we form our field impression. Did your general impression come with hands-on? Did your general impression require hands-on? No. Does a field impression require hands-on? Yes, it's all the way at the bottom of the sheet. You did all these things before you arrived to the field impression, the diagnosis of the patient. So you understand what the test question is going to look like. Okay? A field impression is the diagnosis, and we get that from sample, we get that from OPQRST, we get that from signs and symptoms. Everybody with me? Let's go through the parts. Onset. Everybody tell me what onset is, what you're going to quickly get wrong. What's onset?
How long has it been going on?
He says how long it's been going on, and everybody says that. Everybody tell me what time is. Say, how long it's been going on, Joe? Would we put two of them up there if they meant the same thing? Onset does not mean time. We still have medics in the field. Onset 20 minutes. That's just everything it says. If I got in the back of the truck and that's what they said to me, I don't care what else they say. They're stupid. Because this is EMT knowledge. Onset is not time. It's how the time came on the patient. Were you okay 5 minutes ago and suddenly your left arm doesn't work? Does that hit you different than my left arm hasn't been acting right for 12 weeks? One of those is a stroke, and one of those is a neurological nerve issue. One of them is an emergency that will kill you, and one is not. Onset is to determine the emergent nature of the complaint. Did it come on you suddenly or gradually? Those are the two options for onset, and they're the only two options. Did it come on you suddenly or gradually? This is diagnostic. If I've been having a little bit of trouble breathing, I run around and I exert myself, and it's been getting worse for 6 weeks. And now at night I can't lay flat. I'm beginning my diagnosis, and now I have a fever every night before bed. Pneumonia. Pneumonia has a gradual onset, gets worse over weeks, presents commonly with fever, has localized lung sounds. These are the ingredients. If you looked at any diagnosis, it would be your grandmother's ingredient cards. That's all it is. And I'm getting those ingredients from sample and OPQRST. I could take the same patient complaining of trouble breathing. I've been having some trouble breathing. How long? 5 minutes. Did it come on you suddenly? Yeah, I was fine. And then I wasn't. Asthma, anaphylaxis, COPD. You see how I'm doing this? Trouble breathing is 150 different potential diagnoses. How do you get to which one it is? Onset. Does that make sense? These are the ingredients. Onset has two options. The sudden come on or gradual come on. Everybody good with that? It does not have the meaning of time. Let's move to P. P are big words for y'all. I don't know why, but most people in America don't know provocation and palliation. What does it mean to provoke something? Yeah, if you're standing outside with a gun and I say, do it! That's provoking, and it probably won't go well, right? If you tell me every time I look at my left arm, my neck just shoots this firing feeling right up my spine, and I say, okay, do it again. Ow! Okay, that's provocation. I'd stop doing that. You hear medics say that dumb crap all the time. Oh, well, every time I look at my arm, okay, don't do that. Son, idiots. Okay? Provocation is makes it worse, while palliation is makes it better. If you miss provocation and palliation, you might not know that Mama gave that 1-year-old Tylenol already. Here you go repeating the dose. She did something that makes this better. She did something to treat this. What did you do to make this better or worse? I gave Tylenol. Well, I didn't ask, so I didn't know. So I repeated the dose. Tylenol is histotoxic to children. It will result in them needing another liver. Important? What makes this better or worse? To provoke something needs to make it worse. Palliative care always means to ease suffering. It always means to make pain suffering
it's better. If you go into palliative care, you probably had cancer, so you're in hospice. Palliative care is giving buttload of pain medication to ease your suffering. That's palliative care. What makes this better first?
Well, this has been going on for a few nights, but I've been stacking pillows underneath my back, and so when I do that and I'm sitting up, I can breathe and I go to sleep and I don't wake up. Oh, then you have CHF. It's just that easy. CHF is a gradual onset, typically speaking. CHF is followed by diagnosis in history, typically speaking. And CHF that comes on as an exacerbation is exacerbated over days of time, made better by the patient doing things like getting out of bed and going and getting in a recliner. You have CHF. Done. That's how I did it. It's not magic, and I'm not super smart. I followed a cue card. It was almost like someone was holding it in the left field, and I was reading off of it. CHF, ma'am, get in the truck. Okay? All you've got to do as we go forward is memorize the mnemonic, understand the pieces and parts of it, and then apply it to the recipe card. And it equals a field impression. Simple. By the end of this class, they're going to say the patient is presented with the following. What's wrong with them? And you got to choose. This is how you choose it. Everybody good with that? What makes it better or worse? What did quality mean in rate, rhythm, and quality? What's the quality part of the pulse? Strong, weak. What are you doing to the pulse right now? If you were taking it, Madison, but you're telling John about it, quality means to blanket to him. Right? Describe it to him. Quality is how we describe things. You better write that down. Quality equals describing. I got chest pain. Oh, it's so bad. Man, what does that chest pain feel like? Burning chest pain is vascular and it indicates abdominal aortic aneurysm. Crushing chest pain, statistically, almost always, excepting in women and small children, equals MI. Just that simple. I just know the recipe. You say it's stabbing, burning, moves from the center of your chest up your back. I have an issue, I have blood pressure, and I don't take my medications. You're having it. Like, give them the stretcher. It was just that easy. Chest pain is too big. How do I make it small? OPQRST. Breathing trouble is too big. How do I make it small? OPQRST. Man, what's the trouble breathing feel like? It starts in my chest and it's moving in my throat. I feel like it's in my throat. My throat's closing. That's not CHF. That's anaphylaxis. That's not COPD. That's asthma. The people experiencing those emergencies describe those types of breathing troubles. Does that make sense? All we're doing is following. When you watch Dr. House, they weren't incredibly smart people. They studied recipes. The patient says stuff. I apply it to the recipe. You understand? Quality. How do they describe that chest pain? How do they describe that trouble breathing? Here's some quality for you. Describe that to me. Like, what do you mean you feel like it? Well, like grabbing my Papa's 357 that's in that brown drawer right there. It's got 5 rounds in it, 7 Magnum. They're hollow points. I'd like to get it out, and I'd like to shoot this whole room up in myself. Is that pretty descriptive? You better believe that shit. Let's leave this room. That's how this works. Quality means to describe. Can you take a broad complaint, sign, symptom, and put it on a field impression? Quality means to describe. Region or radiation? Where does that hurt? Boop. Okay, region. Radiation means what? Does it move? It is very common of myocardial infarction, which is the fancy word for heart attack, for that chest pain to start underneath the sternum, feel like a pressure, and move into the left arm and jaw. It's just common. That's just what that heart attack does to people. So when someone tells us, God, I got crushing chest pain and my jaw is throbbing, that ain't a toothache, you dummies. Let's get in the truck. There's a reason why they're profusely sweating. Let's not take them to the dentist. Let's take them to the cath lab. It's just that simple. Understood? Region and radiation. Does that pain move anywhere? Severity is pretty easy. I got some chest pain. Okay, sir, on a scale of 0 to 10, what would my chest pain be? What do they say? 25. That's a 10. Only 10, dummies. All right, 0 to 10. That's severity. But how would you do, that can only be done with pain. Do you agree? No, you could apply that silly stuff to something else. What if I have asthma? And I've had asthma attacks. And you guys have come to me for asthma before. I've even been admitted to the hospital with my asthma. Can I now do severity?
It's asthma.
And that's how you do severity on stuff that's not pain. Okay? You'll hear us say to asthma patients, have you ever been intubated with asthma? Statistically speaking, if an asthma patient gets intubated, it is downhill from there in their life. They will get intubated again. They will go on a vent again. And eventually that will result in some chronic, horrible things that happen to them. Severity is not just a 0 to 10 scale for your pain. Compare this event to other events. Very important in COPD. Very important in asthma. Very important in CHF patients. So know where we are today. If the patient says my HOMO2 is 88 and they're COPD patient, they're chronically ill with breathing trouble. The next question out of your mouth is comparing severity. What is your normal SpO2? 88. Well, today I'm 89. Not that bad, right? If you had 89, I'd be like, oh God, let's get out of here. But this guy has 89? Not that bad. You understand severity? Timing is pretty easy. How long total has this been going on? If it's been 5, 6, 7 weeks and it's getting worse, you have some type of infection. You do not have anaphylaxis. Make sense? Just that simple. Okay? Those things take time to grow. Those things take time to get worse. Anaphylaxis goes from 0 to Jesus in 5 minutes. There's no time frame for 2 weeks with anaphylaxis. You'd already be in the hands of the Lord. Okay? Everybody good with OPUST? Everybody good with sample? These are big acronyms. And test questions are going to break this acronym up more than any other acronym. I ask you individual pieces and parts and granular information about sample and OPUST. Everybody good with that? So you must know it, and memorizing it alone ain't going to get you far. You must practice it. You must go out, find a complaint, and see what onset means. Okay? So think about that. In all of this history taking, OPQRST, sample, you are trying to diagnose the patient. Been out of the country, sir? Do you have all your vaccines? Do you smoke and drink? The alcohol, drugs today? Are you eating today? These are simple questions in your history taking with your sample, your OPQRST, adding those little questions that will clue you in. If I just got back from Africa and I didn't take the malaria stuff when I was there because my doctor advised me not to, I might have malaria. That just makes good sense. But you won't know that if you didn't get into the history. What you're going to find is that patients will be holding on to the entire problem, and they will say nothing to you because you didn't ask them. I think that's stupid, but they're not informed. They're not professionals in the medical world. They don't know what parts of information that they know are important to you. They don't know which ones matter most in diagnosing their problem. So if you don't ask the right questions, you likely will not get good answers and you won't be able to form a field impression. Everybody good with that? Take 10. I'll leave. What I do. Do this. Another shot. Go to them closely. Don't, by any means, let anyone. Okay, that goes in there.
I'm trying to.
December. Getting there. Such a drug.
It is. Other than fruit, vegetable, seed, or
No, you're fine. Just push hard. Yeah. No, we have access.
that's what I'm sure.
Yeah.
That's all.
Yeah. What's that?
What do you want to go? Going through everything. Study.
Right. Yeah, it's going.
Service first. Everybody through that.
Chief Association sad about being consistent. So I was trying to get them, but we got it yesterday. So they got right. This product is different. And we're asking about scheduling, sorry, solution management, certification license. You're asking for a one-stop shop here. What they're trying to do is good. Trying to provide some amount of solid, some amount across the smaller. So it's a good intent. It's just going to the money is there. That's right. Absolutely.
So
I was pretty excited about it. That's going to be really good. I'm interested.
Working 24/7. Study. Doing that. So, I don't know if you're working with that.
I thought Monday through Friday. I don't have hours. Good job. Good job, EC. Good job, EC.
So,
I know, man. Sometimes
will I be there?
I'm sick. But
That's wrong. Understand that?
it's just a test.
Somebody will say, offering?
Should I reset that?
Yeah.
Just straight up Parker.
Sure.
You know, 15-minute Parker.
Yeah, it's all like, oh, station.
I said it. That's so bad. Station.
Oh, did you? Yeah,
Yeah,
yeah.
I got a station. It's a daily call. That's worse. So I went to the station there.
Oh, that's the data individual sent the truck, but not wrecking the city's truck.
Joe, is it true that only one tanker connection to an engine.
Yeah.
That's the
One tanker?
There's
Yes,
only
yes,
one tanker in
Nichols.
the county.
Nichols.
Okay.
But everything else, like ours, we got 4-inch suction discharge. But the thing that gets me about the way half this county was trying to do task forces or do a tanker shuttle with nurse. It's not how you do a tanker shuttle. You set your tanks. If you don't have somebody who knows how to drive 2 tanks, you find somebody who knows how to drive 2 tanks, and you run tanks.
Right.
And
I'm a little shocked. 5-inch, but maybe you just don't need to.
Well-
I'm just not experienced enough.
well, the bad part about it is, well, not the bad part. The cost on a tanker to be able to put a pump big enough on it to supply a 5-inch, that's not what you might as well buy an engine. Because most tankers and
So the general tanker is running a 2.5 into the end.
most time, yes. If you're going to repair off tankers,
And the GPMs for that do not appear distinct. You're not struggling.
as long as you have enough areas, you have set good fill point. I don't want to say pump capacity, but come pretty close to pump capacity on.
Have you ever been in scenarios where pull everybody out, get back in, and out, yeah,
It is, that goes,
we just don't see that a lot. Okay.
right, and that goes to, just like our, second, she was saying, your closest hydrant is on Haynesville.
Yeah, I'm gonna say,
It's on the back side of the state. My closest hydrant to that is in the country club parking lot. That's why as soon as I got there, or when I was pulling up, Kenzie and probably was on fire. That's why I said go ahead and send me a tank and make these. That'd be enough for the initial getting it going.
yeah, let's.
And if it was big enough to make an initial song, exactly. More capacity. Because we already had South End on scene. So y'all are on it. And y'all are on it to provide and the thing that go to the sink. Y'all go to the water. Don't you take 5 minutes in 2.5. You're trying to fill tanks. There's not but like.
So I can do
There's only 2
We're
tanks.
still getting 5.
Like our, like so like capacity. So that because it's just it's not a restaurant. That's the only time I have to worry about. Other than that,
Alright, kids, getting back to it. Finding everybody and myself is being recorded. So let's take that into account. This is again covering the nitty gritty of each piece and part, which I'm not going to do with you. I'm going to give you the overriding foundation, and you're going to read the gritty. So you have to read the chapter to understand some of the granular pieces that you might see on the testing about what things can compose history. Okay, beyond the normal stuff. All right. Patience is really important. It's saying closed-ended questions require simple yes or no, and open-ended questions are allowing the patient to describe. There are times we would use a closed-ended question. Do the people you wish to harm today, are they in this room? Yes. That's a good closed-ended question. But if you say, does your chest pain feel under pressure? That's a bad closed-ended question because they'll simply say what? Yes. So I wouldn't want to use closed-end questions very much with Opicurus T and sample. There are pieces and parts where it would be great, but mostly speaking, closed questions would get you into a little bit of trouble. They'll simply just say yes to everything you ask, versus an open question allows them to describe. It allows them to really give you that information that's locked in their head that you're looking for. Okay? So be aware of that. You are going to see test questions simply asking if you understand the difference and the outcome of closed-ended questions versus that. Patients are going to tell you a lot of stuff. They're going to be over talkative, so you're going to have to find a way to put that on the path you need it on and get the information. They're going to tell you 10 things that make no mattering to one thing of very important information. So you're going to have to be able to siphon through all that and figure out what's good and what's not. You already know the signs and symptoms of shock begin with anxiety and mental status changes. One of the things we see providers doing that's really odd to me is that they will get as emotionally charged as the patient is. If I'm struggling to breathe because my throat's closing, I get to active, but you do not. So if you listen to dispatch traffic, you'll hear this a lot where the dispatcher gets just as animated as the caller. That's not allowed. We had a dispatcher in an area around us get on the radio and get animated with the officer screaming, shots fired, shots fired, shots fired, because he was on the wrong channel. She's just kept screaming back at him, you're on fire! You're on fire! First of all, that means he's on fire. And so now we must dispatch fire trucks. That's odd, since he's shooting someone. She did get his man, so that's good. But she is animated because she's fearful that he's on the wrong channel and she can't help it. She, in that moment, didn't realize she could stand up in her little cubicle to the dispatcher channel he's supposed to be on and say, your guy's getting shot at. Just that easy. Instead, she keeps up her radio and starts screaming back at him, you're on fire! You're on fire! So that went to the news. That got pulled. It was a FOIA. And they played that traffic nationally in this country to hear our dispatcher getting animated at someone who was potentially going to lose their life on the radio. So you can't do that. They get to be animated. We don't. We have to siphon through that. So be careful with that. When people die, when they are experiencing emergencies, they lose their faculties. And they are going to be anxious, angry, hostile. They're going to curse. They're going to call names. They're going to do stuff that should cue you in that this is bad, but it instead triggers your lack of emotional maturity. Don't be those people. We have physicians that do that at the bedside while people are dying. Don't be those people. Become hypoxic, you can't think. You do really bad things. You start saying bad things. You start being so fearful of dying that you act a fool. Don't let that stray you from patient care. Go through the horrible and figure out what's wrong with them. Just keep interacting. Keep talking. What dispatchers should say is, okay, I hear you. What's your address? Where are you at? What's your address? That's what they should say. But instead, they start going right at it with them. And then they don't get information. That's really dumb, number one. I would fire that dispatcher in a second. Most importantly, you aren't going to find that address. You aren't going to figure out that this is an anaphylactic reaction. So you are now anti. So be careful with that. Obviously, we deal with a lot of intoxicated patients. I don't do well with anything. My emotions are fine. I'm working at $90 an hour. I plan to get them back. That's the allegation. So, crying is a thing we deal with a lot, and that's fine. Try to be understanding the best that we can. Remember that confusing and weird behavior might be a product of the emergency. Okay, I have a big regret in my career. I didn't do anything wrong, but I assumed that this patient was doing what all patients do, and they were just being dramatic. I had a patient who was rolling around the floor of the crocodile rolling, and would not interact with me. This person could answer their name, where they were, they could tell me their complaints, but they just would not stop this rolling. I mean, it was so dramatic. They ended up getting out of their clothes, and they were butt naked by the time we were dragging this person out. I'd put the monitor on, they'd roll the monitor off of them. I'd get a vital sign, they'd take the vital back from me. We'd try to get a BGL, all we could do was stick the finger. I mean, this person was fighting us from doing anything. And it was very dramatic. It wasn't obvious. It was just restlessness. They had a core body temperature of 86 degrees. They had an abdominal thoracic sepsemia. Something had gotten into their belly and infected it. She died that very. And we thought she was being dramatic. Because all of our patients are like that. All of our patients are dramatic. You must believe them until you have a means to prove them wrong. If we had been able to get enough vital signs, we said, okay, this is bad. But we couldn't get any vital signs on this person. We couldn't assess this person because of their condition. And so if we'd have had vital signs that said that she was okay, then we could have assessed it as drama. This is drama. But in the absence of those things, I should have believed them. Didn't impede anything. We took her emergent, called for more resources because we couldn't keep her on the stretcher. We literally had to hold her onto the stretcher. This person was dying. They weren't being dramatic. They were dying. Okay? So, don't let this stuff get you in trouble. Cultural barriers, try to acknowledge them where we can. This is a part of the chapter. This is testable material. Obviously, there are people with a lot of different beliefs than we have, but just customs. Try to honor that. Okay? Be careful with people. That could be a conversation all by itself, but I'll let you. Language barriers, call the language hotline. Most 911 centers pay for access to the language line, which is an American resource. Other countries have too, but it's a resource that we can call. And there's folks who speak endless amounts of languages very fluently, and they're just on the other end of the phone. So you put your phone on speaker, you ask the question, the person gives it to them, that person talks back to the phone, then the person on the phone gives it back to you. And in pretty quick time, you can get information where you were struggling before. Language line works very nicely and very quickly. You can't assess people very well. You can't talk to them. Don't raise your voice at them. Although that is commonly thought by people in the South as a means for which you begin speaking Mandarin, it just makes you look an idiot. So if you raise your voice because you now understand you less and they're pissed. So there you go. Don't raise your voice. I'll let you read that. If people have glasses, hearing aids, things like that, make sure we bring those with us to the best of our ability. If we can, do that. Secondary assessment. This is the name for the head-to-toe assessment, which also is the name for the entire section that we're on the sheet, so don't let that confuse you. So this secondary assessment right here is the head-to-toe assessment, where we actually look at the patient's organs. Here's something to write down and remember. In the trauma assessment, our head-to-toe is DCAP BTLS. So put trauma, head-to-toe, DCAP BTLS. D, C, A, P as in Paul, dash, B as in boy, T as in Tom, LS, DCAP, BTLS. That is how you do a head-to-toe on a trauma patient. If it was Joe, I'd physically take my hands, but his head not say, I'm moving. This is intact. Where's DCAP, BTLS? And you would go from head to his toe, looking for DCAP, BTLS. That's a trauma head-to-toe. On the medical side, we're not looking for bones to be broken. We're not looking for a traumatic mechanism, DCAP, BTLS. We're looking for organ function. So on the medical assessment, I would expect you to say, how is his neuro doing? How is his HEENT doing? Head, ears, eyes, nose, throat. There's another acronym for you to write down and recall. How is his neck veins? How is his trachea? What am I doing for you right now? It's a video. It's a video that you're going to have to go watch to memory on the JBL Teachers Helpers that says head to toe medical assessment. You're going to have to go watch it. In that video, I teach you to do a medical head to toe assessment, where we look at organs and how they are performing. I go head to toe so that I don't miss anything. And when I look at Joe's head, what I'm thinking is neuro. That's a brain. When I look at his face, what I'm thinking is HEENT. Head, ears, eyes, nose, and throat. When I look at his neck, I'm thinking of neck veins and his trachea. When I look at his chest, I'm thinking of heart and lungs and great vessels. When I look at his abdomen, I'm thinking in the right upper quadrant is the liver, and the left upper quadrant is the spleen, the right lower sections are the following. That's what I'm thinking. And I'm going to palpate all those quadrants. When I look at his pelvis, I don't think about his pelvic bone, because this isn't a trauma. This is a medical. So I'm thinking about what's inside there, and it would be his GIGU, gastroenterology and gastrourinary system. How are you peeing and pooping, Joe?
This is the last time you peed. Have you had any diarrhea? Any constipation? That is a part of the head to toe. Then I'd go down to the arms and legs. Looking for PMS. What's PMS? Pulse, motor, sensory. You gotta be putting these on flashcards. Pulse, motor, and sensory function. I'm gonna check that in how many extremities? All the ones that exist. That would probably be 4 for the rest of us. Yep. 4. So PMS times 4 is pulse, motor, and sensory times 4. And I'd look at his skin color and temperature. Again, I'd open up his shirt to see if he had any hives, any rashes. Doesn't that go into what we do? If you're on the assessment of an anaphylaxis patient and you forget to look at skin in your big head-to-toe assessment, they will not tell you that there's a hivey rash on the belly going all the way up the chest. You will have missed it. And they will make a note that you missed it. You want to know how to do the head-to-toe medical assessment? Go on to the learner helpers, and you will go to the video that says National Registry Medical Assessment Head to Toe. In this class, when we practice head to toes, we'll make you stay head to toe. Because if you begin to jump around, you will not come back to an important organ system. Okay? Take a look at your sheet real quick. How many points are available for the head-to-toe assessment? 5. How many things can you assess there? How many systems can you assess there? Neuro, HENT, head, neck, and chest, lungs, heart, great vessels, skin, musculoskeletal, psychosocial, vaccination. That's a lot, but there's only 5 points. So what does that mean to you? We want you to go to the systems that matter most based on the patient you have in front of your face. I don't need you asking an asthma, breathing trouble patient if they feel safe at home. That would not be a part of the assessment. It wouldn't get you any points. So you got to go to the systems that you think matter for the patient in front of you. You have to assess those systems. If this was a breathing trouble patient, I would do neuro, because hypoxia leads to neuro changes. I would do HENT, which means what again? Head, ears, eyes, nose, and throat. I would do lung sounds, because lung sounds matter with breathing. That's the assessment that I would do. That would be enough right there to say to the examiner that I understand the organ systems that can be affected by breathing trouble. Chest pain, same assessment, because those are the organs affected by chest pain emergencies. Does that make sense? Okay, where are you going to go learn how to do this? On JBL, there's a video. There are videos of me doing entire assessments. There are videos of me doing trauma assessments. There are videos of me doing decap BTLS. There are videos of me doing head-to-toe medical. It's all there. Just have to go do it. Understood? Okay? So on a medical patient, my head-to-toe looks at what? Organs. The trauma patient assessment head-to-toe looks at the what? Decap BTLS. So let's go through that. On a medical assessment, I did revelation, great vessels, chest, and heart, lungs. I went down and said, that's all organs. On the decap BTLS, I'm physically palpating for the following things. I'm physically inspecting for the following things. I'm physically thinking about the potential for the following things. Deformity. Contusions. There are going to be test questions that say what separates a contusion from a bruise. Contusion is a big ugly one. Fine. It's making overflow versus a bruise is very small. They're caused by the same thing, which is what? Bleeding. Okay? Contusions and crepitus. C has 2 of them. Not one of them. C has 2 of them. Crepitus. Crepitus is what? Yeah, I feel a bone and I go down the length of the bone. I go down the length of the bone and it should be what? Intact. It shouldn't give way to me. If I go, that yanks out at you, it makes you want to vomit, and that's called crepitus.
Okie dokie? You would never have found crepitus if you weren't physically going all the way down the patient. Understand? On your trauma exam station, should you get it, you will physically go all the way down that patient. Or the fake injury that they've created, they will not tell you it's there. Okay? Crepitus is the instability of bone underneath. A. Abrasions. Abrasions or scrapes. Think of road rash. P. Punctures and penetrations. Think gunshot wounds, stabbings, arrow through the leg, rebar through the spine. All kinds of really TikToks. Penetrations. B. What is it? Burns. T. Tenderness. L. Lacerations are different than abrasions. And the test question might simply be comparing and contrasting the two. S. Pay close attention to deformity, tenderness, and swelling. Those are the three findings of DCAP BTLS that catch broken things not visible. In a child, their bones are called green stick bones. They bend more than they break. So children will walk on a broken bone because it is intact, more so than had a 80-year-old experience the same exact mechanism. So you won't see that big, ugly, obvious broken bone that you would have seen on the 70-year-old. You're going to see deformity, crepitus, maybe, but it's going to be tender and swollen. That's what you're going to see. The tenderness and swelling catches what you can't see with the naked eye. Pay close attention to that. Super important. If Joe just took his hand and slammed it in some type of machine at work, pulls it out, and it looks okay, he's like, it's 10 out of 10 pain, this thing's killing me, and I waited an hour to call you, broken. Until I can see it on an x-ray, it's broken, because it should have gotten better. The tenderness should have gotten better. Okay, so until I x-ray it, it's broken. And I'm just going to assume that it is so. Because you can break things almost. You can break things some. You can break things very little. And so if you don't get an x-ray of that, and the patient has tenderness, they have swelling, they have some amount of it, it looks different from the left arm to the right arm, must assume that that's broken. Okay? Remember that? DCAP BTLS, form constitution practice, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling, and that roll out of your mouth just like that, or you will not pass a trauma. Those skilled stations are the medical and assessment trauma station. Have we do that? Why? Because it encompasses everything. Everything you learn in this class from its very beginning of the orientation to the end of this class can be encompassed in the medical assessment and in the trauma assessment. So, back to the original question we explored opening up the conversation. How does the secondary head to toe of a medical patient differ from that of a trauma patient? In the medical assessment head to toe, we looked at what? Organ systems. Internal organ systems and how much they were working. Agree? In the trauma patient, it's much more palpation driven. It's much more external driven. And it is using the mnemonic, the acronym, if on exam day you have a chest pain patient and you start your head to toe by saying, all right, this time we'll start my head to toe. Fail. You could have done beautiful the whole way up to that. But now you've demonstrated to the examiner that you don't know which assessment to do. I must now wonder if you can do an internal head to toe based on organ systems. Do you understand that you must know which exam you're doing? You must know whether this is a medical patient or a trauma patient. In the field, the EMS gods might be ugly today, you gave up. What came first, the chicken or the egg? They ran off the road, rolled it over 6 times. We had the RSI, and only to find out, well, damn, the blood sugar's low. That's probably what started all of this. This was a medical patient that led to a trauma patient. But in the exam world, we keep it white and black. It is obviously medical or it is obviously trauma. Understood? So, which exam are you doing? Do you know which exam you're doing? So make sure you stick to it. Yes. You're going to have a fake patient there who is very obviously medical and very obviously trauma. And the only way to screw it up is if you simply aren't doing the work. Okay. Moving forward. DCAT BTLS right there. It is our goal, as you can see here, to find and begin treating any bad thing within 60 to 90 minutes. On the medical side of things, you'll see 90 minutes, like the bleeding time for MRIs. But on the trauma side of things, you'll see that from the time you began to bleed to your belly to the time your ass was on an operating table and putting the bleed to a stop, you got 60 minutes if you want to statistically survive that event. And everybody thinks that means that you would die before then. No. However long I let that go, the less likely when I send you to the ICU, we're all high clapping and praising each other for being so damn good and safe. 2 weeks, you will still die. The longer your body experiences what we call insult, you were kept from the normal homeostasis. The more likely you will struggle to survive, the more likely you will fail to survive, the more likely you will go into multi-organ dysfunction syndrome. The 60 minutes never simply meant that the patient would survive if we stopped the bleeding in 61, 62, 63, the patient was still bleeding, but we stopped it. They're now more likely to die because you exited the hour. What do we call that hour? The golden hour. That's what. The trauma patients typically are confined to the golden hour, while the medical patients, like stroke and heart attacks, in the 90-minute zone. Make sense? All of these things are considered homeostatic insults. They can be very small, or they can be very gross, like multi-system trauma, where multiple organ systems are inflicted by trauma. The point is, how many minutes did the cellular level experience hypoxia secondary to insult? For every single one of those minutes, there's data. Does that make sense? Okay? A focused exam gets talked about a lot in this chapter. You need to read about what they're meaning. You have fast exams, emergent exams that say head to toe, this patient comes out right now. And you have focus. If you were describing the two, would you call the primary a fast exam or a focused? Fast test question. Would you call the history taken, vitals taken section, the field impression forming section, sample, OB-QRST, would you call that a fast exam or focused? Okay. Focused. It would be focused. It takes time to do. Okay? Here's the next level of that same question. Okay? Are there patients who are doing so poorly that will never truly get to focused examining? We can still do a secondary, but it will be fast and it will be down and dirty as quick as possible because we can't get to a focus. Let me give you an example. You gave them 2 milligrams of Narcan. You've been bagging the hell out of them. You gave them 2 more milligrams of Narcan. You're bagging the hell out of them. They are still unconscious. They're still not responding, and they're still not breathing on their own. So we package them, we load them in the ambulance, and we start taking off towards the hospital. We give them 2 more milligrams of Narcan. Nothing happens. You're a BLS unit. That's all you can do is breathe and Narcan. And they're never coming around. Are you ever going to make it to a point where you can slow down and be like, where's your vaccination history? Can you give me your last time out of the country? No, you will be confined to emergent treatment the entirety of that call. Do you see how this is moving? It is a moving target. It is fluid. You may not ever make it to a space where you can truly focus. Know that fast exams and focused exams exist mutually or exclusively, no matter where you are on the sheet. If I'm in the secondary exam but the patient is still emergent, that's not going to be focused. It's going to be more rapid. That makes sense? Can you still do a head-to-toe in a rapid secondary? Yeah, I can listen to lung sounds while Joe bags the patient. But we're not going to go knee deep in palpating 72 quadrants and asking his GI doctor on the pharmacy line the last time he pooped. We don't care because he ain't breathing. So we're not going to ever get there. Does that make sense? So know the difference between a focus and a fast exam. And know that you might even have a patient that you were doing a focus exam on because sudden change, now that's out the window. Okie-dokie? Everybody good with that? Questions about that? So take a look at the literature, the book. Take a look at the book, and it references rapid exams, rapid primary, rapid secondary, and focus exams. Can you do a focused primary? Can. What kind of patient would it be? A stay and play non-emergent. It'd be a hangout. Granny can't sleep. She needs to go to the hospital. Okay, well, Granny checks out. Everything's fine. Let's take our time. Let's get her bed slippers, her favorite nightgown, her umbrella in case it rains, call 62 people from church, have her pastor come meet us at the scene. You can do all that because Granny's not emergent. So your primary on Granny would probably be more focused. Okay? Typically speaking, on an emergent patient, can your secondary exam take place on scene? No. These are the exploring questions that are coming your way. On an emergent patient, you would not typically see components of the secondary done on scene. Understood? Now you're thinking to yourself, Justin and I work in this field, and we do secondary things on scene. Sure you do. You have enough resources to do it. The book, the exam, the National Registry curriculum comes from the perspective that it's you and a partner. Are you guys going to be whipping out every tool in your toolbox on scene of a patient who's dying in front of your face? No, you're not. So the secondary of an emergent patient would most likely take place in the back of the ambulance, and that verbatim is a test question. Make sense? If Granny's load and go, you would be doing the secondary stuff on the primary. You'd be doing the secondary. Down the road. The hospital. Whatever I get done is what I get done. Make sense? Okay. We would not stop and get the slippers. I mean, Justin would. The rest of y'all would. All right? So you already know what normal looks like. This is getting into your big head to toe and telling you things about how to do that. I cover all of that in the video that you're seeing. This is a particular slide that you've got to pay a little bit of attention to. The breath sounds, the breathing sounds. There are upper airway sounds, there are lower airway sounds. Snoring, where did that come from? You're laying in bed next to your spouse and they're snoring. Where's that coming? The upper. Why do people answer questions differently when I make it medical? You knew that snoring was upper when I said your spouse. But if I say it connects to this book, somehow you just can't make sense of it. It is very basic, folks. Snoring comes from the upper airway. It's the same reason why you have to slap your spouse 6 times with a pillow and say, go get on the couch. It's up here. It's up here. Make sense? Wheezing takes place down here. You're going to see test questions that say, which one of these sounds are upper airway? Which ones of these sounds are lower airway? Wheezing, crackles, bronchi, they're all lower. Snoring, gurgling, stridor, they're all upper. Write that down. Upper airway sounds. Stridor, snoring, gurgling. That's all upper. It's taking place above the larynx. It's taking place in the nasopharynx, oropharynx, hypopharynx. It's upper. Snoring, stridor, gurgling. Those things suggest that the upper airway needs intervention. While wheezing, crackles, bronchi, those things take place in the lungs, and you would only have heard them by doing what? Auscultating with your stethoscope. If you heard wheezing, you heard it because you were auscultating. If you heard wheezing out loud, it would be called a what? Stridor, and that's upper. The same exact noise, occurring for the same reasons, but in a different place. Understood? If I take your pharyngeal tissues and I burn them, and they feel with edema, they will begin to squeeze. And as air passes those burned, squeezed tissues in the back of your nose and mouth, it will make a squealing noise. That's called a stridor. That exact same squeeze occurring in the bronchi, in the lung fields, is called wheezing. Understand? One is upper, and you treat that differently, and one is lower, treated differently. And that's why we must know the difference. If you went to attack upper airway sounds with the same toolbox as you were treating lower airway emergencies, it would not work very well. If you give albuterol to a baby experiencing croup and epiglottitis, it does not work because albuterol acts on the bronchi, and that is not where the emergency is occurring. Everybody understand? Let's take a look at the other words on the screen. There's a video on Justin's helpers on JBL, on instructor helpers on JBL, that has lung sounds. The best that we can really do. Lung sounds are hard. It takes a long time to learn lung sounds. You've got to listen to 100 patients with good, normal lungs to ever understand a patient with bad. Does that make sense? But the video gives you wheezing. You get to hear it. Stridor, you get to hear it. Crackles, you get to hear it. Okay? Let's make some notes. Let's make some notes. We already said which ones of these are upper. We've said which ones are lower. Let's talk about lower lung sounds, which are wheezing, crackles, bronchi. Here's something cute. Crackles and bronchi are the same thing. But we just like to call them different things, and then we like to give them notations like dry or wet. They're the same frickin' thing. What it means is that some amount of fluid, thick, watery, is in the lungs. Bronchi and crackles are similar. Crackles infers wet sounds. So if you listen on the thing, it sounds like you're blowing bubbles in chocolate milk. And that's what's happening. There's fluid in the lung space, and as air moves through it, you hear it bubbling. If you heard that, you'd be like, oh, gosh, they have CHF. There's fluid in their lungs. Here's the treatment for that. Bam! Done. Okay? If you have bronchi that is dry bronchi, it's pneumonia. If I was listening in all the fields and everywhere was clear and equal breath sounds, except one space, that'd be bronchi. Bronchi indicates pneumonia. Write it down. And it sounds like Rice Krispies. It sounds like the milk crackling Rice Krispies. It's very dry. It's very fine.
He said bronchi indicates
Pneumonia. And it will be localized. It will not be all over the lungs. If it were all over the lungs, you'd be looking at a really sick patient, would you not? But crackles, congestive heart failure sounds, that's merely fluid, free fluid, like water in the lungs. It is so much like water that if you lay the patient flat, the water moves. You sit them up, the water goes to a certain place. Agree? So where would you more likely hear crackles in a CHF patient sitting up? In the upper airways or the lower airways? The lower. The water's going to go where the gravity pulled it. So I listen in the apices and I listen in the bases. If you look back at this slide, the patient provider is listening at the what right now? Apex or the base? The apex. If I have fluid on my lungs, I would hope not to hear crackles in the apex. Would you agree? You would hope that that fluid is not enough to be that high. That when you sit the patient up, the fluid should accumulate at the bottom of the lung. Agree? Here's the problem with that. What is the fluid covering in the bottom of the lungs? Alveoli, because they live in the most inferior and lateral 20% of the lung field. So where that fluid is accumulating is where those alveoli are. So the fluid smashes them closed and they won't do their job. Agree? So let's go back over these lung sounds. Snoring, upper or lower?
Upper.
Stridor, upper or lower? What is a stridor?
Closing the throat.
High-pitched squealing noise from constriction of the upper airway. Agree? Okay, test question all by itself. What differs a stridor from wheezing? The anatomical location. Simple real estate. Where did it happen? It happened in the throat, stridor. It happened in the bronchi, wheezing. Got me? Okay? Crackles. Upper or lower? Lower lungs. And I would hope that crackles is occurring where? In the bases. In the bases of the lungs, because it's fluid. It's congestive heart failure. It's a drowning patient. They were in the pool, they were struggling, but it's okay now. We got them out. Well, I listen to lung sounds, and I hear crackles. It's not okay. We're going to the hospital. Well, I'd like to refuse. I feel better now. We're going to the hospital. You have fluid in your lungs, and by tomorrow, you'll be dead. That's called secondary drowning. How many times have your dumb hick friends gotten out of a trouble scenario, what we call an emergent water event or a submersion-based event, and now they're okay? And they go home. You are taking a gargantuan risk. Those people suffer from something called secondary drowning, where that fluid accumulates and accumulates and accumulates, smashes alveoli until you're asleep. You don't know you're in trouble, and you die from hypoxia in your sleep. This stuff's important. Crackles will be in the bases, and it means they're not okay. Drowning patients, congestive heart failure patients, toxic exposure patients to poisons or smoke, those people will fill their lungs with fluid. Bronchi, upper or lower? It is lower. And will it be all over the lower lungs, or will it be confined to specific spots? It'll be confined to specific little spots, because that's where the bacteria began to accumulate, and that's where the mucus began to try to fight the bacteria, and so then that's where the sound is. The rest of the lung is fine, because there is no infection there. Does that make sense? So bronchi is found locally. It's isolated, secure to a space, and is fine crackles that sound like Rice Krispies. Bronchi indicates what infection? Pneumonia. Go on to video. Listen to these lung sounds. Are they lobular or are they all over? Something we call diffuse. Lobular would be bronchi. Diffuse would be crackles. Are they upper or are they lower? These are the questions you're going to face about lung sounds. Can I do that? Learning to say that it is take a lot of time of you taking a stethoscope and listening to normal lung sounds. So I encourage you, like we did in the vital section, I said go feel a lot of pulses. Go feel your friends, go feel your family, go feel your mom, go feel your dad, go feel your wife, your husband. Because those people are all probably okay. You're not going to go out to the field and feel sick people pulses if you haven't gotten a good grasp on feeling healthy. And lung sounds are no different. It takes a long time. I have got to trust you. If I drop an endotracheal tube in someone's throat, I have got to know that your left lung is clear and distinct. If I don't trust you, I have put that tube all the way down their right main stem, and they're only air in one lung, and you let me do that for the last 45 minutes, and now we have a pneumothorax. That's how important this stuff is. I've got to trust your assessment. When I walk in the door and you say, Justin, they're hypertensive, they have a history of cardiac MI, they take multiple cardiac medications, they have JVD, their blood pressure's through the roof, and I hear crackles. I'm not going to redo that assessment. I'm going to grab my vent and put it on the patient because I trust your assessment. And everything you said screams CHF. So I trusted you, and I put the patient on the vent rather than repeating my assessment. Your knowledge base is the difference between a medic who listens to you and believes in what you found or dismisses it and starts over. You're talking 5, 10, 15 minutes of costing patient time. You got to be good at this stuff, and it takes time to get good at it, okay? So lung sounds are difficult. They're hard to grasp and wrap your head around. They take time to prepare. They take time to practice. Go practice them. Listen to the video. Think about where to listen to lung sounds. Look at where we listen on the patient. Apex, apex, base, base. Midclavicular line, base, base, fourth and fifth intercostal. You got to go read the material. Okay? This is what we will practice this week in lab. Listening to heart tones, they're clear and distinct. All I want to know is that when you put the stethoscope over their left ventricle, which by the way is just around the midclavicular left line, you're going to hear bump, 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 bump. If that bump, bump sounded like it was under a swimming pool, well, that's a problem. If the bump, bump sounded far away, that's a problem. I don't need you to know any nomenclature of sounds. I don't need you to know any technical medical versions like murmurs, S1s, S2, S3, S4s, gallops, I don't need you to know any of that. You simply need to tell me if the heartbeat sounds close to you and normal, clear, distinct, or muffled and distant. Those are the two options. Clear and distinct, you should be writing that down, or muffled and distant. If there's something between you and that heartbeat, sounds like it's underwater, sounds like it's far away from you, then something is wrong, and the medic might need to do something about that. The sac around the heart can fill with blood and fluid, and if we don't stick a very long needle into it and do a paracentesis or cardiocentesis, that heart's going to stop beating. So if you want to see something really cool, just find muffled heart tones on a trauma patient and watch your medic stick a 20-inch needle in their heart. Okay? Cardiocentesis. Pretty freaking cool. Go to YouTube, put in cardiocentesis, and it will be right there. Pretty cool. You know what a normal heart rate is. You know about qualities and rhythms. You know how blood pressure works because we talked in the vital signs. Do you see now why we started them as we did? It's too much. There's no way you can do all this in one chapter. This is a whole module exam in and of itself. So you have to commit what we've learned thus far to memory. Everything we've shown you, it must now be stored. These are the symptoms that can potentially indicate a neurological issue. What's syncope? Passing out. Passing out. Fainting is syncope. Alright? Altered mentation, dizziness, drowsiness. Stupor. What does stupor mean? It's close to stupid. The patient should be acting normal, but they're just out of it. They answer your questions, or they're mumbling their answers. Well, that's stupor, and stupor sounds a lot like stupid. That's how I remember it. Probably not very 2023, but it works. The other word for stupor is worse, and it's called obtunded. O-B-T-U-N-D-E-D. Obtunded is used a lot with babies, and it basically means unconscious. So I keep doing things to them, and they don't care. I stick a needle in their arm to get an IV, and they didn't. That would be obtunded. They don't care. And that would indicate something else. The Glasgow Coma Scale is going to be introduced in this chapter, but you do not have to necessarily commit it to memory yet. You might see some information on it, but we will have to commit Glasgow Coma Scale to memory, and you will see this on the test question where it says the patient has the following signs. What is their GCS? That's where we're going. And that's a pretty hard question. It's a level 4. Even for experienced instructors, exams can be somewhat subjective. And so then I might get one number less than you. So if you don't have a good familiarity with the score, you're going to be lost on that question. Okay? Glasgow Coma Scale, also known as GCS, has 3 parts. Eyes, verbal, motor. Its only job is to determine how awake the patient is. Well, you're very awake if you move your eyes on your own. You're very awake if you speak fluently and oriented. And you're very awake if you can tell me to get lost and walk away from me. GCS 15. Got it? It comes in eyes, verbal, motor. 4, 5, 6. I'm just kidding. 4 is the max you can get in the eyes, 5 is the max you can get in verbal, and 6 is the max you can get in motor function. What's the lowest you can get? 1. So what's the lowest GCS you can get? 3. You got 2 types of 3s. Dead 3s and alive 3s. Both of them are pretty bad off. Agree? Yes. If you don't move your eyes at all, to nothing that I do, you have a 1 in eyes. If you cannot speak, you make no noises at all. I stimulate you, I rub you, I poke you with needles, and you make no noises, you're a 1. If you cannot walk, move, do anything to the poking and the prodding that I'm doing, you're a 1 on motor. But are you dead? Did we say they were breathing? We didn't say nothing about breathing. Did we say there was a pulse? We didn't say nothing about pulse. So you can be dead in 3, you can be alive in 3. Both of those patients are in trouble. If you were asleep in your bed right now, and I took a 14-gauge needle and I popped it into the bottom of your hill, which we commonly will do to neurological patients, you'd wake your butt up real fast. So that person is okay. Doing that to a person who doesn't respond is very in trouble. You'll see us do trauma patients where we take the back of our shears and we'll rub them up the bottom of their foot. Should make the plantar surface cover over and pull away from us. If they don't do that, you know that their brain's off. You take a finger and you put it in someone's rectum, they don't immediately squeeze that finger and try to get you to stop doing what you're doing. They're GCS of 3. That's how we do that. And if you are a GCS of 3 and we intubated you, you're probably not going to survive. That's how we find these things out. That's how we know what we can't see. I can't take a CT to your head and say the brain's okay. If everything looks okay on there, you might still be dead. But if I put my finger in your butt and you don't do anything about it, and I didn't give you a medication to make you do that, you're probably brain dead. And in a couple of weeks, we're going to keep testing and testing and testing to see if that gets better. And if it doesn't, declare you brain dead. Does that make sense? Okay, so GCS is an advanced method of AVPU, consciousness, and orientation. But as we intubate people, as we put them to sleep, as patients experience neurological issues, it's not enough. You need something more than that. And that's GCS. If you call in a trauma patient and try it, you don't tell the GCS, they're going to ask you for one. Once you get out of this class, you never have to worry about GCS again because you can calculate it. Click, 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 and it gives you a number. But you got to know it for anything. Does that make sense? Once you get out of this class, RTS, RAS, stroke scales, they'll all be clicks on your little dashboard, and it'll pop you out a number. But until then, you got to learn it. Until then, you got to be able to calculate. Okay? That's GCS. Pupils. What did we learn in vitals that they should be? Pearl. They should be pearl, and pearl means what? Pupils are equal, round, and reactive to light. What the left one did, the right one should do. Does it take work from the brain to make the pupil small or big? Small. It takes work from the brain to make the pupil small. If you pulled anyone out of the morgue, you shine a light in their eyes, the pupil would be 10 millimeters. That's as wide as a pupil can go. And that's because their brain is what? Gone. So they're not going to constrict their pupil. A clinical sign of death is a pupil bilaterally at 10 millimeters. You might even still be trying to breathe. But if half your head is open, your pupils are at 10, you are dead. You ain't going to live, no matter what we do. Everybody good with how pupils work? Work to constrict, passive to dilate. So we understand that? You don't get that now. You're going to struggle later because we're going to give you a problem and ask you, what would you expect this person's pupils to be based on the problem? If I'm on cocaine, cocaine makes my body think I'm in fight or flight. In fight or flight, do your pupils widen or do they constrict? They widen. Half the class will get it right and half will get it wrong. Why? We think of pupils in reverse. Let me help you. If you were running from a bear in the wild right now, trying to survive, and you knew that your pupils were the window into your brain's ability to see, do you want the window open, folks, or would you want to close it? You'd open it. When you're in fight or flight, your brain's ability to see is based on the window. The window is your pupil, and you want that bad boy wide. I caught myself. You'd want it wide. Okay? So then if I'm on heroin, and my brain's been told to go night-night, you don't see anything. What's my pupil? It's super small. Constricted. It's just that easy. If you're up, fight, high heart rate, high temperature, high breathing rate, wide. I need all the window. I want to be able to see. Fight! But if you're taking a substance that puts you out,
It's very little. Are we good with that? Okay, pupils. They should be pearl. You're going to see a word in here called anscoria. Anscoria means what? Unilateral or non-bilateral pupils. One looks different from the other. About 20%, based on the literature, depending which one you're reading, 20% of the population in the world has some amount of anscoria. So if the patient's a conscious, alert, and oriented patient, you would say, ever been told your pupils are weird? And if they say no, that anscoria is probably important. Okay? I have heterochromia, which means my pupils change colors. They just go to different colors, and there's spots in my pupils. So you might see that, and you would say, is that normal for you? I know that I have that because every freaking eye doctor I see says, oh my gosh, you have heterochromia. So they would know if they have eye check. Okay? Anoscoria in normal people that is non-symptomatic does not change. And so they would know that they have anoscoria. Here you go. So B and C are pretty obvious anoscoria. Hear that? B, I gave a lot of ketamine to. All right, there's why we check pupils is the brain. It tells on the brain. What is the brain doing? Is it fighting or is it asleep? Is it in trouble? Is the left pupil's big and the right pupil? That brain's in trouble. Okay? These are the things that change the pupils, and they're all ugly, they're all bad. Here's Pearl. This is just more assessment stuff of what you can do. This is all on my video. You guys must look at the abdomen in quadrants, 2 upper, 2 lower, right versus left. And you're going to see a simple test question that says, what is the large amount of organ about question? My 6-year-old knew that. We would practice it in the car ride on the way to our house in Daniel Island on an everyday basis. So you have to know it. These are simple, simple things. Okay? My 6-year-old would also put down a king tube, but our home's a little creepy. I'm trying to raise Navy SEAL. Or a Daniel Island. You already know decap, because notice I did not bring it. Because we know he. He's going to be playing video games by the age of 6. Pulse oximetry, you know how that works, and you know how it can fail, you know what it should be. You might see a simple question in this module that says, what should blood pressure be? Everything's fair game in this module. Capnography, capnometry, we taught it to you already. So this is the stuff you looked at. This is the stuff you learned in labs, but you probably haven't looked at since. You might want to revisit those notes that you made. Okay? Test question. If you're in the back of the ambulance with an emergent patient who's trying to die, at minimum, every blank minutes we would assess the patient. 5. You're in the back of the ambulance with Granny who got her bed slippers and her best bed cap, and she called 62 of her pastors to come see her at the church line. Granny gets assessed every 15. Every 5 for emergent people, and every 15 for non-people. Let's go through the chapter questions. Y'all want to barrel through, or you want to take a 5? Barrel through. Barrel. Stay focused with me. I know it's been a lot. During the scene size up, you routinely determine all the following except. So this question is simple. Do you know SNACM or don't you? The ratio of pediatric patients to adult patients? Let's hold on to that. Mechanism of injury and nature of illness, we certainly do. Whether or not additional resources are needed, we certainly do. If they're in hazards, that's our safety. So I agree based on these answers, even though it's an a-hole way to form it, and you're taking the test, you'd be like, do know that in scene size up. You do. But based on those answers, B is the only stupid one. Agree? Guys, you got to get that in your head. You're going to be on the National Registry. Better you choose for every single answer right. And you have to choose the most right. You arrive at the scene of an injured person. As you exit the ambulance, you see a man lying on the front porch of his house. He appears to have been shot in the head. He's lying in a pool of blood. What do you immediately think? This is the assessment chapter, and so your brain went right to, how do we say that?
D.
Meanwhile, we should leave, retreat to a safe place away from law enforcement. Does this happen to us? Megan Golbus, one of the lieutenants on my engine, AOS engine, who works every B shift, she was at Dorchester County's BLS crew chief, and she went to fall. Well, he did fail. He had faulted when they shot him in the head, and they were the only unit dispatched. They walked into a traumatic arrest, secondary to gunshot wound, with the shooter on scene. Oh, damn. What do? I'll tell you what Megan did. She went right over there and tried to save that man. But her partner was like, gotta go! Don't leave your partner in the house. Even if it's Megan, I get it. I'd leave it too. But you can't leave your partner, so tell them to get out of the house. They should have left that house. It should have never been in the house. Okay? So, don't go straight to taking care of people. Think about scene safety. This happens to us, guys, especially on the MBAs. I love MBAs. You can separate good medics and bad medics on an MBA real fast. Because a bad medic is going to walk up to the first car with a bunch of people hurt in it. Go to town. You are a bad medic. If I don't have 6 ambulances coming for the 12 patients on this scene, you're a bad medic. It doesn't matter if you save all those people in that car. You're a bad medic. You don't know how many number of patients there are, and that was in Sacco. That's where we began. Ready? All right? Findings such as inadequate breathing or an altered level of consciousness should have been identified in the primary. Don't be stupid to yourself and say, well, I'm going to identify everything. As we do it in the secondary tip. Don't do that to yourself, because some of y'all will be going back and checking your answers. We do it in the primary. Which of the following would you not detect while determining your initial general impression? Why would you not have found D in a general impression?
You
Don't touch them. General impression is a non-touch assessment. Your primary assessment of an elderly woman who failed reveals an altered level of consciousness and a large hematoma on her forehead. You protect her spine, you give her oxygen, then you should. Told you it was kind of C. Transport the patient immediately. Let's take a look at all the answers, because these questions are tough. Okay? Make sure you read all of them. Reassess your interventions. Where would that happen?
Secondary.
In the secondary, so it's out. We reassess in the secondary. It's out. Perform a rapid exam. Would you do a rapid exam with this patient? Yeah, but wouldn't you say you did?
That's why you're
I'm going to hold on to that one. Transport the patient immediately is certainly a good answer. Perform a focused assessment. Would you be focusing any of your assessment on the patient that's doing all that? Not Justin. I'm not. I'm not doing a focused exam. Once I get 5 people back to the drug and all the interventions to save lives are done, then I would do it. So out of these choices, I would either go with B or C. I have to choose C because I think B would have been done. Okay? So I'm going to read it again to make sure. The primary assessment of a woman who builds also consciousness, a large hematoma forehead, after spine, administer oxygen, you should be for inhaling. I'm going to go with. I really want to go with B.
Only one way to find it.
Yes! Your instructor's so good! This is an asshole question because you can only go off of what they gave you. Okay? I went with B because they didn't say it was done. And so I only could go with what they gave me. They were coming from the perspective that because you saw those things in your general impression, because they were already found as bad, you already did something about them. Does that make sense? So one of the rules of this chapter is when you find something bad, you must do something about it. And so in their general impression, they saw that she was unconscious, so they jumped ahead and they said, that's bad, give her a hypoglossal. So then a rapid exam. It didn't say anything about bleeding, and that's what bothered me. Didn't look for bleeding yet. And so then I went and said, I know that probably makes, I know that question's not as nice to you as it was other questions. So if you're angry, I get it. But that's why I went with B. And I didn't know if I would be right. Okay? So they say B, and I love this part. They say that you'll get our rationale when you go through the answers. Their rationale is simply that it was correct. Because we said so. That's exactly what they went with. A semi-conscious patient pushes your hand away when you pinch their earlobe. What is their level of consciousness?
Yeah.
I agree. You had to do something ugly to get something back, and so I'm going to put them as pain. P on the after scale. I do disagree with the way they formed the question. You should have said, what is their responsiveness? Right? You should not have said their consciousness. C. Assessment of unconscious patients' breathing begins by, I bring you to the clear and distinct positioning of the patient. They are unconscious. Let's do some good learning because the question gives it to us. They don't go deep enough in this. They're asking the more basic question, but let's do some learning. I walk up on an unconscious patient. How do I assess BPC?
Put your fingers on there.
Simultaneously for no more than 10 seconds. The moment they became unconscious, they became a cardiac arrest until otherwise. Understood? You do not go A, B, C on unconscious people. You go C, A, B. That's a test question. Unconscious people get C, A, B. Look at me. First off, it's breathing and check simultaneously for breathing and a pulse for no more than 10 seconds. That is CAB. Unconscious people are presumed to be cardiac arrests. Agreed? If you know they're breathing, they have some amount of consciousness, you would proceed in the primary as A, B, C. Okay? They don't get you that deep here, so what do you think your answer is here? I would go with respiratory rate and depth. Do we walk right up to people and throw in opiates? No. Do we do a lot of manual head tilt chin lift stuff in a potential cardiac arrest patient anymore? Do we do all that anymore? We don't. We have a heavy focus on compressions. And so they went with B. Manual position heads. Well, that's absolutely stupid. Let's look at their rationale. At least they gave one. You cannot assess and treat an unconscious patient's breathing until the airway is patent. That is, okay, so they went from the sheep's perspective of ABC. I do not like that question at all. I would have gotten it wrong with you. I don't like it. But we should have included in, now that I'm looking at their rationale, we should have included that they didn't go CAB. They didn't talk about simultaneous checking of pulse and breathing. So I should have been on that method. You should have been too. But it's their fault for taking an unconscious patient to ABC. I hate that. I got it wrong. You're welcome. 12-year-old patient can speak only 2 to 3 words without pausing to take a breath. Their serious breathing problem is known as what? B bravo, 2 to 3 words dyspnea. What does the word dyspnea mean? Trouble breathing. DYS means what in front of anything? Difficulty, trouble, bad, neurasthenia, anything. Breathing. So even if you see some big $9 medical word in the pulmonologist's office, if it has PNDA behind it, it's to do with breathing. How should you determine the pulse of an unresponsive 8-year-old? This is a tough one. Unresponsive, so would I ever go A? Nope, A's out. Palpate the brachial pulse in the inside upper arm. That's a maybe good answer. The only reason I don't like it is because the 8-year-old's probably got a good carotid. But it is a correct way to do a brachial, so I'm going to hold on to B. Palpate the radial pulse with your thumb. That's another radial. It's out. Palpate the carotid pulse in the neck. So you're between which two answers? B and D. Oh, I hate D.
Would you say B? Just
I'm going to go with, this is a child because they don't indicate the child is signs of puberty. You go off of what the question gives you and this is an unresponsive 8-year-old with no other information, I must Doopy. It's D. I hate this answer. Okay, so how many people went with D? Raise your hand. I wanted to do D so bad. How many people went with B? Now memorize the answer. You're welcome. Memorize the answer because that will be the exact answer on that phrase. And Corey's it this way. Okay? Now memorize the answer. Good thing for you guys is you're going to get to this class where you because you're doing test prep, which is making your own quizzes coming from the same bank that I get your miles away from. You're doing quizzes every week, and you're doing module exams. And I'll leave them open for you to review. You've got the entirety of this class. So, memorize the answer. Coming up, sir. In an unresponsive patient older than the age of 1, you should palpate the carotid. I like it. I like it because in the class we said, if it's a defined neck, probably be okay. Probably. But since they made him 8 and didn't talk about puberty, so it's D. Palpate the carotid. He's over the age of 1. Commit that to memory, okay? Over the age of 1, the natural resolution perspective is go to the carotid. When assessing your patient's pain, he says it started in his chest and it spread to his legs. This is an example of what part of the OB is T. Region of radiation. Y'all are so excited.
Yeah.
Stay. Thank you for the question.
Anyways.
All right. I think we covered everything here. Don't save snack 'em. Let's turn off the OBS. That's the end of the lecture.